Thank you so much, Dr. Rajesh. Now, the next speaker of the day is Dr. Saima Zeb from Hyderabad Medical Complex, Peshawar. Madam, please come on the stage for your presentation.
Rahim. My name is Saima Zeb. I'm a fellow in training at HMC Endocrinology Metabolic Unit. Thank you, PES, for giving me the opportunity to present my case. It's actually a long story of a 22-year-old lady, and I would try my best to cut it short. She was unmarried, and her chief complaint was primary amenorrhea, and she was seeing many health professionals over the last 4 to 5 years for this complaint. During the clinic assessment, her puberty was arrested at tenor stage 2. There were no obvious dysmorphic features, no evidence of other endocrine dysfunction. Her sense of smell was intact. Visual field were normal. And from the old record, I could see that her height was at 25th centile at 20 years of age. We did blood tests. They were reported with low serum gonadotropins in the face of low serum estradiol. Prolactin and other pituitary hormones were fine. She did have pelvic images, which did show infantile uterus and atrophic ovaries. Over enthusiastic, so she also had MRI of the pelvis as well, and it was reported mild scoliosis in the lumbar spine in the MRI film. So we made a convenient diagnosis of hypogonadotrophic hypogonadism. Just to make it more smart looking, we added normosmic idiopathic. And the hormone replacement therapy was advised, as it has happened on and off in the past. I'm sure everybody must be thinking that something is missing. Yes, MRI brain, it should be done, and we advised. Remember, the patient was accompanied by his brother. When I asked for MRI, the brother categorically refused it. And when I asked the reason, he said that my sister has enough MRIs in the past, and I don't want any more. And he took me back in the past about a decade ago, when the patient was actually around the age of 11 years. At that time, she had severe headache with loss of vision episodically. It went unnoticed by the parents. And only when she actually developed the bowel incontinence, she was rushed to the hospital. Here she was admitted by a neurosurgeon. A burr hole surgery was done, and according to them, no shunt was placed, no tumor found or resected, and she was then discharged after a couple of days with no follow-up. She has lost all the record except for some folded films of MRI, which did confirm that she had dilatation of the third ventricle and lateral ventricle, the gross dilatation, but no evidence of any tumor. So we summarized that she might have hydrocaph at that time, and the procedure that she had was ETV. Just quickly revising the brain ventricles, the green is the third ventricle, the single funnel-shaped ventricle that we are interested for today's case. Hypothalamus, I'm sure the most important part of brain as far as endocrinology is considered. So it came to my mind, can we link the hydrocephalus that she had 10, 12 years ago with the amenorrhea? And the answer is yes. Professor Turan in 2001 actually presented a case of 29-year-old lady. She had secondary amenorrhea, had hydrocaph, underwent ETV, successful, and she had the restoration of the menstrual cycle and the resolution of the hypogonadism. To understand this, we need to look at this hypothalamic nuclei. For today's case, I want everybody to focus on this arcuate nucleus, which is located in the mediobasal part of the hypothalamus. All these nuclei have a list of function. For the arcuate nucleus, it is related to the energy balance, reproduction, and growth hormone release. So this is just a rough idea about the procedure. The endoscope is passed through the lateral ventricle into the third ventricle, and then they make small perforation into the floor of the third ventricle, so they allow the drainage of the CSF directly into the nearby system. This diagram is important because it shows the relationship of the floor of the third ventricle with the arcuate nucleus, very precious for this lady. So, naturally, can amenorrhea be a complication of the procedure that she had? And the answer is yes. Mr. Wang is a pediatric neurosurgeon in Houston, and he followed 46 cases that underwent ETV over 3 years, and he found that 2 of them did develop the amenorrhea after the ETV. So, either the hydrocaph or the surgeon has given amenorrhea to the patient. As we were finalizing the diagnosis, her mother came into the room. She was an anxious, overweight lady, fully covered in abaya. While I was talking to her, she had small lumps on her face. And I asked her, has you got similar things on your body? And then she showed me that her whole trunk and the neck was studded with multiple capillary and neurofibromas. She didn't allow me to take image of those except for this part of the forearm, and you can see a capillary paired with a neurofibroma. So the lady was actually a case of neurofibromatosis type 1, undiagnosed till today. This is the criteria devised by NIH in 1988, which was revised in 2021, and according to that criteria, the mother was a case of NF1, as she had 2 of those criteria. Now, the second part is important for my patient, because my patient was the kid of that mother who is now a confirmed case of NF1. So, being autosomal condition, has the mother transmitted the NF1 to my patient? I asked the patient again, have you got anything similar on your body? And she initially reluctant because of the odd places. Then she showed me that there were multiple capillary, and I could see what they call a coast of California on the underarm. So according to the B part of the criteria, my patient was actually a case of neurofibromatosis. So next question, can neurofibromatosis be the main culprit for her condition? Mr. Balestrazzi in 1989 actually presented a case of a boy who was found to have papilledema during the routine screening. He was diagnosed with hydrocaph, and then during the hospital admission, he was found to have neurofibromatosis type 1. Mr. Roth in 2020 claimed that the incidence of hydrocaph is 1 to 13% in neurofibromatosis type 1 patient. And Mr. Murphy, who is affiliated with King's College of London in 2020, he collected data of around 220 patients. And he said that 10% of them were having aqueductal stenosis, and 25% of them were having no symptoms. So it's a long diagnosis, the non-tumoral obstructive hydrocephalus caused by aqueductal stenosis, resulting in hypogonadotrophic hypogonadism in my patient with neurofibromatosis type 1. It's a common neurocutaneous syndrome, highly variable presentation, various phenotype. For us, today's case, the important is the scoliosis that could be from mild to severe in 20 to 50% of the pediatric population, and the optic pathway glioma, which is present in 10 to 20%. But remember, in my patient, there was no optic pathway glioma. The common endocrine manifestation, as you can see, nowhere amenorrhea in this list. And remember, the first 3 manifestations are usually in the setting of the presence of the glioma, where it actually impinges on the hypothalamus. So my take-home message, not all cases of hypogonadotrophic hypogonadism are idiopathic. Primary amenorrhea caused by non-tumoral hydrocaph in neurofibromatosis is still a rare case scenario. Early diagnosis, prompt evaluation of NF1 is important so that we do not miss this potentially reversible cause of hypogonadism. These were the phases of the neurofibromatosis that I was aware of. But after seeing this poor lady, another phase was added to my album. Thank you very much.
So you commented that this was reversible. Did the patient pathology get reversed?
Not in our case.
You just said that.
Not in our case. There have been cases, they collected data, and they said that after the hydrocaph recovery with the ETV, the cognitive functions improve a lot. But the reversal of hypogonadism is not that common, but it's a shot that should be given. Yes.
Was there any other endocrine pathology in addition to the hypogonadotrophic hypogonadism with this patient?
No.
Considering she had a surgery at the age of 11 years?
No.
She
She was
achieved
normotensive.
normal height and growth, everything.
The height was actually at 25th centile when she was at 20 years of age. When I saw her, she was out of the growth chart period and she was 22. Her weight was at 50th centile.
Can you hypothesize any particular reason when the hydrocephalus is relieved and the pressure is relieved from the pituitary and the hypothalamus? Why don't these girls don't recover completely to normal menstruation?
Yes. In my particular case, I would believe they were from the northern part of Pakistan. And I believe maybe it was too late before she was brought to the attention, because according to the mother, she used to be literally blind when she used to come from school. And only when she actually had the incontinence, they realized that something serious has happened. And according to Mr. Turain, the dilatation of the third ventricle actually caused distension of these nuclei, the periventricular and the arcuate nuclei, where the GnRHs are present. So I believe there was permanent disruption of those neurons.
Thank you very much. Much appreciated.
Thank you.
Thank you. We're all set.